So our next speaker is going to be talking about a problem, a challenge, a disorder, an issue very prevalent that you know about, which is PTSD. So I'm going to be introducing to you somebody many of you have heard before in other contexts, and this is Dr. Paula Rauch. So Paula, this is her third appearance here at our seminar. Paula is an extraordinary child psychiatrist, really one of the great doctors with respect to these incredibly challenging times in life, and an expert on the impact of trauma in family life, whether it's the loss of a child, a parent, a husband or wife, devastating physical illness, life-threatening diagnosis, traumatic assault, particularly the impact on children of parents' illness. So Paula was formerly the head of the child psychiatry consultation service that worked with the pediatricians and the doctors in the general hospital with children with psychological challenges with their illness and with life-threatening illness. She's the founder of the Marjorie E. Korf Parenting at a Challenging Time, the PACT program, at the Mass General Hospital Cancer Center. And she holds the Timothy Christopher Davidson MGH Chair in Child Psychiatry, with great thanks to you all and particularly the Davidson family. She also pioneered in helping us establish the Red Sox Foundation and MGH home base program for, that serves post 9/11 military service members and their families. And Paula designed and created the family program for that program, for the home base program. So it's my great pleasure to introduce Paula to talk about PTSD and particular focus on the family.
Thank you, Jerry, and thank you to the Kesslers for hosting this amazing event, and for all of you for giving me a chance to talk about something that I'm excited to share with you, and something that's very much in the news. So in the few minutes that we have together, I hope I'm going to expand your thinking about post-traumatic stress disorder, or PTSD, and the next time you hear it on the television or read about it, a broader, more complicated picture is going to come to mind. So let's call this post-service member or veteran Tony. His is a story that you are likely to have heard on the news. He's a young man who had 2 tours of deployment to Afghanistan, returned with post-traumatic stress. But let me tell you now, a couple of years out from his last deployment, a little bit about his family. So while he served, his parents got up every morning with their telephone next to their bed, worrying about what they might hear in the night, and living with that level of anxiety, went to work every day feeling like most of America wasn't living with the stress that they were living with. In his second deployment, his sister, who had been 13 when he deployed the first time, was now 15, 16, and much more aware of the risk, and she became extremely anxious, and her parents were more worried about her than they were about their own anxiety, and they remained worried about Tony. Between his first and second deployment, he and his longtime girlfriend, despite a lot of conflict, had a child together, and now they were worried about their new grandchild. A couple of years back, Tony continues to have the symptoms of post-traumatic stress, and we'll talk about those symptoms. But many members of his family are doing much better and have been seeing people at home base for support, and I'll talk about those kinds of support. But I also want you to think about someone that we'll call Melissa, another patient who I have known during my years of care, whose youngest child, younger of her 2 children, was born with a congenital cardiac problem that required surgery soon after he was born, surgery again a couple of years later, and careful follow-up. It's now many years since he was born. The incidence of those that serve in harm's way, like Tony, developing PTSD is somewhere between 20 and 30%, depending on the kind of service experience they have. In more recent data, the incidence of mothers of children in the ICU with congenital cardiac problems developing PTSD is 30%. So There are some stories that get told and others that are invisible. PTSD is among us and being experienced by many that we love, and I am hoping to break it down and talk about it more broadly with you. So what's stress? All of us live with stress. It's a stressful world. We all need different ways to de-stress, to turn our distress around and de-stress, that feeling of things piling up. The image for me is there are many days when I feel like I'm running up the down escalator and starting the next day running up the same down escalator. But when we're talking about post-traumatic stress, we're talking about the kind of stress of the sort of fight or flight physiologic experience that is overwhelming, frightening, kind of a terror experience. And we know that all forms of stress, including post-traumatic stress, are cumulative and they impact our physical health as well. So people who live with stress have increased cardiac disease, increased metabolic disease like type 2 diabetes, increased in their cognitive decline, and even on a cellular level, there's evidence of premature aging in the context of stress. So what makes something a trauma? There are traumas with a capital T and traumas with a small t in my world. There are some traumas that everyone would recognize as something absolutely catastrophic, the unanticipated death of a loved one. There are also smaller traumas that may not be appreciated by others, and often with kids, people will talk about bullying as being a trauma with a small t. That child feels alone, alienated, isolated, unsupported, and what is frightening them every day is not getting the kind of understanding in their community that gives them a sense that they're not alone with it. So for a child, something we might not think of as a trauma becomes a trauma. People who have experienced trauma, it's as if their rose-tinted glasses have come off, and now they've put on their gray-tinted glasses, and it changes your whole outlook about the world. When someone returns from Afghanistan, they don't see the world the same way as they did. You can't unremember, you can't forget. Your body certainly doesn't forget the experience of trauma or knowing desperately difficult circumstances. The world never seems quite as safe. I love stories, and I would love to tell you in great detail about all the faces that I've chosen to tell the anonymous stories that I want to share with you. But time precludes my doing it. But I want to tell you just a snippet about each of the faces here. So the little boy up in the corner represents a child that we saw many years ago. Who, after his parents were out to dinner, he was at his grandparents' house with cousins. There was a storm with lightning. The older cousins not actually meaning to bully him or do anything. We're talking about lightning strikes, and they were pretty excited about it, but he became terrified. He was terrified that his parents would die while they were out. And following that evening, he developed more and more and more anxiety about a lightning strike, so much so that he couldn't play his sport anymore, and was fearful that every cloud was going to be one of those clouds and he was going to get struck by lightning. I'll fast forward to just tell you that after a short cognitive behavioral treatment, he's now a freshman in college and on the baseball team. Let me go back and tell you the other stories too. So quickly, Alyssa's story is that her mom dropped her off early once, was heading somewhere, dropped her off. She was on the swim team. She was beginning of her 9th grade year. One of the senior boys pushed her up against a wall, kind of more verbally assaulted her than fully physically, but enough that she was very frightened. She never told anyone. She was angry at her mother. She was complaining a lot about her mother's work. It wasn't clear what it was that had made her so angry. She dropped out of the swim team. And it was only when she developed an eating disorder about 18 months or 2 years later that she revealed this original event that had started her on this path of feeling so alone and alienated and unsupported. And then Bill, who's down in the corner, was an Air Force veteran who was crossing the street near the hospital. It was a snowy day. It was dusk. He didn't see a car coming. It hit him, and he flipped up over the top of the car. He had a couple of injuries, but those didn't worry him. He'd broken bones before. But he couldn't get over the fact that he couldn't come up to the sidewalk and get ready to cross the street without having a full-on panic attack. And he needed help to sort of understand what had happened to him so that he could reestablish a relationship with himself and then get back to work. So we're always trying to understand why this person and why not that person. There clearly are genetic factors that predispose people to post-traumatic stress. A part of the brain called the hippocampus is one of them. If you're fortunate enough to be born with a beefy hippocampus, you are less likely to develop PTSD. We don't get to pick the size of our hippocampus. And it is just an interesting factor. There's concordance, so like identical twins have a lot in common about the likelihood of establishing post-traumatic stress, but it's not 100%. So there are other factors involved. Obviously, life experiences. In Melissa's story, she has a twin sister, and her twin sister has 2 healthy kids and no history of PTSD. And then how families react and what the social support is. And particularly, we are learning amongst our veteran population, where they're less than 1% serve. It's very important for them to have a community with whom to process their past experiences so they don't feel like they're traumatizing others in telling their story. And more importantly, actually feeling as if nobody gets what it was like to be there. So after a traumatic event, most people adjust. So think back to that 30% after really very, very difficult circumstances, traumatic experiences. 60, 70%, depending, and more of people will adjust. Rape probably has the highest rate of PTSD, just over 50%. So it depends on what the event is. But one way to think about post-traumatic stress, or the way I think about it, is that it's an error of memory, one in which fear doesn't turn off. And the reason that you see the book there is because one of my colleagues says, if you think about all your memories as being a book, and every time it drops on the floor, it opens up to the same page. So that's a traumatic memory, is that same page. There is the experience that threat is everywhere, and it's in part because if you're on high alert all the time and things can trigger you into that physical feeling of fright, you really want to avoid as many of the things as you can to avoid that happening again, and it leads people to change their behavior and to do less and less and less. We know that what happens with anxiety naturally is it peaks and it comes back down again. But if people only do the part of feeling the peak, the fear of doing it, for many people, public speaking falls in that same category. And then you don't have the experience of it coming back down. You don't learn the process that is necessary for it to get less and less and less. And safety's not reestablished. In order to study anything, I'm not a researcher myself, or not much. But it's important to have criteria so that we are talking about the same thing. In PTSD, we are looking for changes in arousal. Almost everyone has sleep problems. They are often angry. They are, because they're hypervigilant, they're aroused. They have an amplified startle reflex. They're having daytime flashbacks and nighttime bad dreams, the frightening thoughts, that physical sense, avoiding things, and then also this really pervasive sense that the world isn't the place it used to be. That's the negative cognition part. And we talk about, with these most recent wars, also moral PTSD. So knowing that you have done something, or would have done something, or could have done something that doesn't match your value system if you were not in a war zone, leaves people sometimes who've not done something but know they would, feeling traumatized. Fear has an evolutionary benefit. If you haven't seen this Disney movie, Inside Out, I recommend it to you. It's an emotion we all know, that fight or flight feeling. And without it, people are not safe. It's very important to be able to remember evolutionarily what's dangerous and not do it again. But if there's too much fear, it's really maladaptive besides being painful. Of course, if there were no fear, and there are some parents who come to see me because their children have no fear, that's not so good either. Not so safe. Here's a picture of the brain. The amygdala is a sort of little almond-shaped, brightly colored piece of the brain, and it's where emotional processing occurs, and in people with PTSD, it's overactive. There's the hippocampus, which I talked about, wishing you to have a beefy one. It's kind of more string bean shaped, and it's not shown in this diagram, but it attaches sort of at the back. It's connected to the amygdala, and it's where the process of emotional memory gets processed. So think about the fact things that non-traumatic memories go into your long-term memory file, and they don't keep popping into your present. Traumatic memories don't make their way into that calm past. It's as if they continue to happen over and over again. So that reestablishing of normal memory. And then the prefrontal cortex, I like to think of it as the good parent of your brain. It's the supervision part. It's the part that helps you to have good judgment, to put things into perspective, to know sort of what the risks are. And then all of our treatments work to break this fear cycle that I'm describing. All of the talking therapies involve sort of changing how people think about their triggers or their traumas, getting to know them better, getting more comfortable with them, changing their behaviors, and secondarily then changing their feelings. There are a couple of the individual therapies listed here, cognitive processing therapy and prolonged exposure. It's sort of talking about what was the key trauma over and over again, and adjusting to it, physically adjusting to it by telling it over and over again. And some real life exposures where someone says, okay, on my hierarchy from the thing that's most terrifying to me to the thing that's least, here's something that's about 20% up my list, but something I'd really like to be able to do. I'd like to go out with my wife and not feel like I'm on such high alert that I can only sit at the corner table watching the door. And maybe you don't start on Saturday night when things are banging and people are moving, but you choose a Tuesday, an early dinner, and try that out. Again, it's getting or going into a store. So it's starting with something not so hard and working your way up. There are a couple of really interesting couples therapies. One is cognitive behavioral conjoint therapy. It's the most sought after. The couples therapies are the most sought after therapies in our home-based program. In this one, the first part of the treatment helps both members of a couple, and the couple doesn't have to be a husband and wife or spouses. It could be a parent, an adult child, or siblings, is to have them both really get the psychoeducational part to understand why the person with PTSD is reacting the way they are and helping to explain it. And then the next part is to help the member of the duo that doesn't have PTSD to become a great coach. In emotion-focused couples therapy, there's recognition that everybody has challenges in their lives, and many couples, both members of the couple have their past challenges and traumas, and it's working more from a relational model to help both members of the couple translate the way in which they react to each other. So there's no one medicine for PTSD, but there are an array of medicines, each of which has its role. One thing to consider is, where in the timeline are you? Are you thinking about medicine for people who are entering harm's way? Are you thinking about the challenge of people who have just been, for example, in a car accident, or are you working with people who have long-standing PTSD? What are the symptoms? What are co-occurring disorders? Substance use and depression being amongst the highest. And we use the full range of medicines that we have in PTSD. We're always interested in resilience, all kinds of care about resilience. Resilience isn't not reacting to something. It's making the functional challenges less and less. And figuring out the ways that we can facilitate that, and thinking about prevention. Prevention for those that are going off into challenging settings. I would consider college being a challenging setting, not just a war zone. Treating people after an acute event and treating them long term. I told you a little bit about the boy's story. One of the things that was special about Alyssa, the girl with the eating disorder, is after her eating disorder was treated and she and her mother were back on the same page, together they did a self-defense course before she went off to college. So I would say confusion is the enemy of coping, and fear is the enemy of creativity. And when parents are afraid, it's often hard to be creative about ways to connect with their kids. So I want to end by, we have so many amazing clinicians and researchers at MGH, and I thought, gosh, of all the people that are doing amazing stuff in PTSD, how come I'm the one that gets to come to Palm Beach? So I went around and talked to some of my favorite colleagues to ask them from different places in our department, what are you most excited about? So on the biologic front, Amar Sahai said, since PTSD is a brain disorder that's characterized by the uncontrollable, inappropriate expression of fear, even in safe environments, my laboratory has found a role for new brain cells arising from stem cells in the brain in constraining aberrant or abnormal generalization of fear, and a molecular mechanism which we believe can control this aberrant generalization of fear. So that's what's getting him excited. Eric Hazen, who's now the head of the Child Psychiatry Consultation to Pediatrics, said, the consult psychiatrists are most often the first psychiatric providers to see a child who suffered a severe traumatic injury, car accidents, all kinds of things. Research has shown that the interventions taken in those early stages after a trauma significantly impact the long-term psychological outcome, preventing the development of PTSD in many cases and diminishing the psychological impact of trauma in others. My colleague, Naomi Simon, in psychopharmacology, said what gets her excited is the targeted pharmacotherapy, such as D-cycloserine, that can be used to enhance learning in cognitive behavioral therapy by supporting the retention of extinction learning to stop remembering. Greg from the Benson Henry Institute, what excites him is translating the science, is our mind-body group, translating the science of stress and resilience into an intervention that lowers the former and raises the latter. We can link up clinical medicine and public health in the SMART program, and SMART stands for Stress Management and Resilience Training. It's an 8-week manualized intervention, and it's being piloted both at home base and also at the U.S. Naval Medical Center in San Diego. And then for me, thinking about traumas and post-traumatic stress from a 3-generation perspective is what excites me, because we can harness the power of family members to prevent PTSD. Whether it's a parent with cancer learning how to support the emotional health of their children, to identify PTSD and encourage family members to access care and also to be partners in facilitating PTSD treatment of their loved one. And the no family goes untouched is true, but I also would want to underscore that every family member has a role to play in healing, and it's a great privilege to be able to engage them in doing that. Thank you.
Yes, sir. So we can take a question. One question. Yes, thank you.
Do you use
Hypnosis.
So we do up on the pediatric unit. So we refer to it as self-hypnosis, have done it for, I certainly started doing it probably 30 years ago. I think some of the imaginal versions of prolonged exposure are similar to hypnosis. So it's in the process of visualizing something all done within you. The kind of self-hypnosis that we did up on the pediatric unit was also to give a sense of agency. I talked about traumas making people feel helpless and hopeless. So one of the things that hypnosis is really great at is creating imagery that helps you to feel like you are empowered to affect your future from the inside out.
So we'll take more questions later. Thank you, Paula. That was great.